Good day. My name is Gerald Holtmann, and I'm delighted to be with you today and share our experience with regard to antimicrobial therapy for patients with primary sclerosing cholangitis. Today's presentation is entitled, "Is there time for paradigm shift for treatment of patients with primary sclerosing cholangitis?" Let's have a look at the aims of this presentation. First of all, I would like to have a look at the established treatments for primary sclerosing cholangitis, or short PSC, and ulcerative colitis. I would like to drill down a little bit what is the rationale and the supportive evidence to trial antimicrobial therapy in PSC-UC, and it is not the established therapy so far. And I would like to share with you some details of the Queensland Clinical Network study that trials to treat patients with PSC systematically with oral vancomycin. As most of you are aware, PSC is a chronic disease. It's associated with inflammatory bowel disease, other autoimmune diseases, and the big problem is that many of the patients who are affected by PSC will experience over the course of the disease the manifestation of colonic or hepatobiliary cancers. And the median life expectancy of patients who are diagnosed with PSC after the diagnosis is 12 to 18 years, unless a liver transplant is performed. And this liver transplant frequently doesn't cure the disease, but clearly increases the life expectancy. Now let's have a look at the clinical guidelines. And here I would like specifically mention the guideline of the American College of Gastroenterology. And this guideline clearly stated that there is no approved or proven therapy for patients with PSC. And this is quite disappointing considering the implications the diagnosis PSC has. Therefore, this is a challenging condition. And some of you may wonder, why is a gastroenterologist interested in this field? And my core interest is neurogastroenterology and the role of the microbiome in conditions that are clustered as disorders of gut-brain interaction. Therefore, what is the reason that I'm looking into this? And I would like to share with you this endoscopic picture. This is a patient who was referred from our pediatric colleagues to the Princess Alexandra Hospital for ongoing management. And this patient had the diagnosis of PSC with UC. And I was called into the procedure room by one of my fellows, Dr. Shah, who really is driving this field with me. And I questioned whether this was really a patient with PSC, because what you can see here is a completely normal colon. The mucosa is very shiny, and there's an intact vascular pattern, something which you would not see in a patient who has ulcerative colitis, even if this patient is remission. And this is an endoscopic picture of the same patient before treatment was initiated with oral vancomycin. And this was a treatment that our colleagues from the Children's Hospital initiated, and they were very much interested in this treatment approach for a prolonged period of time. When we drilled down with our patient how the liver function tests were changing after initiation of treatment, we puts this data together. And what you can see here is a different liver function test, ALP, ALT, AST, and so forth. And at a given time point, vancomycin treatment was initiated. And subsequent to the treatment with oral vancomycin, most liver function tests normalized. And this was quite impressive for me, because I have experienced and seen PSC usually at a very difficult to treat condition, sometimes fluctuating liver function test. But here it appeared that the patient had a sustained remission after being treated with this antibiotic. Therefore, we observed sustained normalization of the liver function test after and during vancomycin therapy. I would like to emphasize that the merit for this step is deserved by our pediatric colleagues. We just observed that this worked quite well. But the colleagues at the Children's Hospital did not only just start this treatment, they also published a letter about their experience. Oral vancomycin induces clinical and mucosal remission in children with primary sclerosing cholangitis. Therefore, this was out very impressive data of a relatively small cohort of 17 children. They were all treated for a minimum of 3 months, and these children responded very nicely to the oral vancomycin. When we then looked at the literature, it rapidly emerged that there were some hints that actually antimicrobial therapy could work. And the first paper actually was published from the Prince Alfred Hospital in Sydney. And in 1959, this at a time point when the term PSC was not really coined, and they were talking about ulcerative colitis and patients with pericholangitis. And in this study, tetracycline was used. And the authors reported that this had a beneficial effect. However, looking at the literature and finding out that decades before people have tried vancomycin was not enough, we took the next step, and my colleague, Dr. Shah, then has driven a systematic review and meta-analysis, putting together all the data which was available at that time point. And we published this in Seminars of Liver Disease, and we found a total of 5 studies. 3 were randomized controlled trials, 2 studies were open labeled, and there were 24 adult patients with PSC, and 98 of them had concurrent IBD. A variety of antibiotics were used: vancomycin, metronidazole, rifaximin, and minocycline. And this systematic review focused on the effect on the liver and not on the associated ulcerative colitis. But here are the data. Obviously, there is a significant improvement of liver function tests if you treat patients with vancomycin. But what clearly stood out from the systematic review is that vancomycin appears to be statistically superior to other antibiotics depicted here. Therefore, overall, treatment with antibiotics was associated with a 33% reduction of the liver function test. ALP was considered to be a measure for disease activity. It was also interesting to see that adverse effects that required discontinuation of therapy were rare. And this was seen in only just 12.9% of the patients. Now you may ask, how does antibiotic therapy compare to the traditional immunosuppressive therapy which these patients receive, because immunosuppressive therapy is a standard therapy for ulcerative colitis? And there's not much published critical data about this. But we did a systematic review and presented this systematic review at this year's Digestive Disease Week. And this shows the alkaline phosphatase and the response of AP to the immunosuppression with a variety of biologics. And overall, there's no statistically significant effect. It's just with a standard mean difference of 0.049, which is neglectable. There's only just one immunosuppressant which seems to have an effect, but this is a well-known effect on the bone alkaline phosphatase. Therefore, it is fair to say that immunosuppression with the available biologics, which are widely used in patients with ulcerative colitis and PSC, does not have a beneficial effect on the liver function test. But what about the effects of vancomycin on the colitis? Here are the data of the biologics on the colitis in PSC patients. And this systematic review reveals that there's a 30% reduction of the relevant scores, which seems to be less than what we see in normal ulcerative colitis patients without PSC. Now let's have a look at the effects of vancomycin on the ulcerative colitis. And there are only limited data available. And here I would like to share the data of a cohort of patients who actually failed to respond to the typical biologics and immunosuppression. The upper panel shows a fecal calprotectin, and the lower panel, the Mayo score. And after initiation of treatment with oral vancomycin, there is a remarkable reduction of the disease activity with regard to the ulcerative colitis. And this is sustained. And here we didn't have a standardized protocol after X weeks measurement, but all these patients were followed up for at least 3 time points, which could have been 12 months or more. And what you can see here is that there is persistent reduction of the inflammatory activity in these patients. And what is equally important, that none of the patients developed antibiotic resistance, which is always a concern if you do long-term antimicrobial therapy. Next question could be, why do antibiotics work? And we clearly have pathophysiologic concepts for PSC. There's a leaky gut concept, there's gut-liver T-cell trafficking, and there is a belief that colonic antigens may drive the biliary inflammation. And clearly, there are a variety of factors which could play a role. And therefore, this could drive the question, is the gut responsible for what happens to the bile ducts? If you want to read more about the potential mechanisms and the mediators of beneficial effects of microbiome-targeted therapies, I can refer you to this review article, which we published a couple of years ago in the American Journal of Gastroenterology. In a nutshell, we have predisposing factors and we have a defined pathophysiology, which is characterized by abnormal trafficking of lymphocytes from the gut to the liver. We have the microbiome in the small intestine and the colon, and we believe that the microbiome changes the bile acid composition. And this altered bile acid composition ultimately changes the risk and the inflammatory activity in the liver, but equally the inflammatory activity in the colon. What is interesting to note that the improvement of inflammatory activity in the colon occurs after antibiotic therapy, even if the patient had decade-long disease manifestation. However, the improvement of liver function does not occur frequently in patients who had many years of PSC. Therefore, it appears that the changes, the structural changes in the liver are irreversible after a period of time. And it makes sense that the fibrotic changes that occur and ultimately require a liver transplant do not go away with a simple course of antibiotic therapy. But the disease process that drives colonic inflammation can be changed even after many years of PSC. Therefore, this is our disease concept right now. We have a genetic susceptibility. We have altered bile acid metabolism, and the microbes in the gastrointestinal tract play a critical role for this. And vancomycin alters the gastrointestinal microbiome, and as a consequence, we observe distinct changes of the microbiome with shifts from firmicutes to proteobacteria, and this most likely reduces the production of secondary bile acids, which play a role for the disease progression. There are quite a number of studies who looked at the gut microbiome. What is here important to keep in mind, these studies looked at stool microbiome, therefore the end product. They did not look at the microbiome in the gastrointestinal tract, in the small intestine, where most likely the metabolic events happen that trigger the inflammatory process in the liver. And these are data of, in total, 520 patients. Their conclusion was so far, the microbial diversity is reduced in PSC. Genus and species level findings are inconsistent. Therefore, they have not been able to identify a very specific change. And the question still remains, can the gut microbiome be used as a biomarker for PSC or the risk for the development of PSC? So the big challenge here, can we find a needle in the haystack of one or more microbes that play a critical role for the manifestation of PSC? Because vancomycin, which appears to be the most potent antibiotic, has a very narrow spectrum. And many antibiotics with a broad spectrum do not work as well. And there are two considerations which we need to keep in mind. First of all, vancomycin is very specific, but vancomycin also is not absorbed from the GI tract. Therefore, it's a topic effect which will remain throughout this transit through the whole GI tract. And this brings us to the Queensland Clinical Network study. We were fortunate enough to attract funding from the Medical Research Future Fund, and we're doing a study at the moment involving several centers in Queensland. We aim to recruit and randomize in total 34 patients with and without associated IBD. These patients will be randomized to receive oral vancomycin 125 milligrams 4 times a day or placebo. It's a crossover study. This means that all patients ultimately will be treated with active medication, and we aim to have 10 centers throughout Queensland. The recruitment is in progress. We have so far 22 patients treated, and there are the centers Princess Alexandra Hospital, Logan, Sunshine Coast University Hospital, and the Queensland Children's Hospital who are online. And we expect that other centers will start recruitment in the very near future. What are the take-home messages? I think what everybody knows is PSC is a rare disease. Unfortunately, it has a very poor prognosis and requires treatment, and most patients will experience over time deterioration of liver function, and their quality of life who will be affected by the ulcerative colitis. The data we have so far suggests a targeted modification of the microbiome in the gastrointestinal tract, and antibiotic therapy may change, I need to be cautious, may change the course of the disease, changing the course of the PSC and the associated IBD. Our task at the moment is to define the precise mechanism, and in particular the role of microbes. And I think we see a paradigm shift. And to be honest, if I would be patient with PSC or a relative of mine, I certainly would give consideration treatment with a drug like vancomycin, which is safe. There are certainly considerations with regard to the development of antibiotic resistance, but I've seen this impressive remissions of patients. Therefore, for me, this is clearly an option that needs to be considered. Preferentially, all patients should be treated within clinical trials, but since this is a rare disease, there are not many clinical trials underway where patients are treated and the data are generated. I would like to thank you for your attention, and I also would like to thank my team who helps to manage these patients and generate the data which hopefully will change the lives of patients affected by PSC in the future. Thank you.